next speaker, after the photos, is Alexandre Moreira-Almeida, whose talk will be the World Psychiatric Association's position statement in religion, spirituality, and psychiatry. Dr. Moreira-Almeida was trained in psychiatry and cognitive best therapy at the Institute of Psychiatry of the University of São Paulo, Brazil, where he also earned his PhD in health sciences. He is currently the professor of psychiatry at the Federal University of Juiz de Fora School of Medicine and founder of the director of the Research Center in Spirituality and Health in Brazil. He's chair of the World Psychiatric Association, AA, section on religion, spirituality, and psychiatry, section on spirituality of the Brazilian Psychiatric Association. Please help me welcome Dr. Alexandre Moreira. You got everything? You got it.
Well, good afternoon, everyone. Thank you very much for being here, and I'd like to thank the organizers, especially Sonia Doi, for inviting me to allow me to be in this amazing environment, seeing old friends, but also meeting very nice people that I'm now getting to know. And also I'm very glad in seeing again Professor Harold Koenig. I was his postdoctoral fellow 12 years ago, and despite we have been exchanging a lot of works and working together, publishing together, but we have never met again. So we are meeting each other again after 12 years. It's a great pleasure being here indeed. Thank you very much. Well, we are in the end of a long and very productive day, and I'm glad that you survived here. And as we are spiritual persons, we know that those who resist until the end will be saved. So that's it's essential to keep this in mind. Okay, my idea is to present the WPA, the World Psychiatric Association position statement on religion and spirituality, to discuss the research and clinical implications. So the idea we will cover how the mainstream psychiatry, the World Psychiatric Association, that represents more than 200,000 psychiatrists around the globe, how the WPA is integrating in spirituality and promoting in psychiatric training, clinical practice, and on research. So there is hope. This is important. So the position statement was published 2 years ago at the journal World Psychiatry. The World Psychiatry is the psychiatry journal with the highest impact factor in the world. So it's a very prestigious psychiatry journal from the World Psychiatric Association. Okay, it's freely available, this paper. It's also the religionpsychiatry.org is the website of the WPA section on religion, spirituality, and psychiatry. So this position statement and many more materials can be freely downloaded at this website. So feel free to access. So basically, we will present here the main aspects of the position statement, and we will illustrate this with research and also specifically the clinical implications. So when it starts saying, this is all quotes from the position statement, the WPA and the WHO have worked that are scientifically based and at the same time compassionate and culturally sensitive. Quite often, or too often, we think in a dichotomous way that if we had to choose between to have a more spiritually integrated approach, a culturally sensitive approach, or an evidence-based approach. We don't need to choose between one or the other approach. We must actually integrate all this approach. We really need to have a biopsychosocial, spiritual integrated approach. So we need to mix the best scientific evidence available, as we will discuss here, and we have discussed during the whole day, and a culturally sensitive, a spiritually sensitive approach. We don't need to choose between any of this. As Professor Koenig said previously, there are literally thousands of studies about the implications of spirituality to health. And the implications of religion and spirituality for the prevalence of mental disorders, for the diagnosis, the treatment, impacts outcomes, prevention, quality of life, and well-being. So we need to take into consideration this because it impacts all aspects of mental health. Okay? So just to give you an idea, although we have learned and discussed a lot nowadays about the secularized world, how our current world is highly secularized. However, do you know how many % of the world population declare to be affiliated to one religion? How many % of the world population declare to a specific religion? Guess. 6%, 30%. 84% of the world population. 84%. So by large, report having a religious affiliation. This data from the Pew Research Center is the best research center about world religiosity. And this is the distribution. And among the 16% that report having no religion, we have a lot of spiritual but not religious people in there. Okay? But it's another important aspect. From this 16%, about 8%, half of these people, are from China. In China has some problems with religion. And people are afraid of reporting their religiosity, including because surveys on religion in China can be performed only by the government that is anti-religious. So people don't feel that comfortable in disclosing their religion in these surveys. So as we can see, it's very, very prevalent, the religious affiliation. So even in this called secularized world, is not that secularized actually. So there is much more religious affiliation, and even among the unaffiliated, there is a lot of spirituality in these people. And there are some predictions about the future. There is a very nice study also from the same group about how will be the religiosity in the world in the next 30 years. So based on several very nice studies, the predictions are that which groups do you think will decrease in the next 30 years? Christians, Muslims, Buddhists. Which groups do you think will decrease the share in the world population? All of them? No. Christians will keep basically the same. Muslims will increase, but to about 30%. The two groups that are actually shrinking are the unaffiliated and the Buddhists in the world population. So it's very interesting to see, and to see how sometimes what the actual data differs from what we read in newspapers or sometimes what we listen to even in many academic environments. So I'm just trying to show here that we have nowadays at least 6 billion people. Okay, and even what about some key spiritual beliefs? For example, that people have a soul and there is life after death. People are afraid to talk about this strange stuff, but Actually, basically all spiritual traditions believe in some sense that we have a soul and there is some sort of life after death, that there is some transcendental existence beyond this current life. It is based on the World Value Survey. This is also a very important research initiative about surveys around the globe. Here we have in the world. We don't have China because China did not allow to ask these questions in this survey in China. Okay? And as we can see here, by large, most of the world population believe. Okay? The only country that's below 50% is Russia. But this data here from Russia are from early 90s. Okay, just after the fall of communism. And there are more recent data actually showing a huge increase of religious affiliation in Russia. And actually nowadays, the unaffiliated, religiously unaffiliated in Russia are similar to US. Even after 4 generations of strong state-support atheism. So it's showing how spirituality is really part of human nature. Even if they try to suppress for 70 years, all people in schools and universities in Russia, in Soviet Union, they had obligatory classes of scientific atheism. And the religions were suppressed, the religious leaders were in concentration camps. But despite that, as soon as it was allowed again, it flourished again. So it tells us a lot about the implications of spirituality to human beings, and also perhaps how the secularization thesis that the whole humanity is becoming secular and non-religious and non-spiritual faces several empirical problems. Okay, and regarding the empirical, so first, by large, most of world population is religiously affiliated and has strong spiritual beliefs and things like that. And what about the evidence? Well, I'm very glad in coming after Professor Koenig, since he basically presented here earlier the main findings for the 2 editions of the Handbook of Religion and Health. These are the state of art, the best systematic review of the available empirical evidence of the implications of spirituality to try to do here now is to present some other studies and also showing some other data from Brazil, showing scientific data similar what has been found here. Because most of the studies have been conducted here in the United States, there is some questions if this data also applies to other countries, to other cultures. And here, Scopus is one of the most important scientific databases of scientific papers. And here we made an analysis which countries have published the most in the last 10 years in spirituality and health. Okay, religion, spirituality, and health. As we can see here, the first country is United States, United Kingdom, Canada, Australia, and Brazil, and Germany, Iran, India, Netherlands. So as we can see here, the countries that have been published the most, the first are English-speaking countries, United States, United Kingdom, Canada, and Australia, and then we can there is a lot of interesting stuff has been published in different countries, as we see here also in Iran, in Netherlands, and other places. Okay, let's see some example, some data about this. This is a study produced by our group of religion and spirituality on bipolar patients, bipolar outpatients. We investigate 168 bipolar outpatients, and we investigate the levels of religious involvement and how it impacts their levels of depression, mania, and quality of life. And it's interesting because we did not find any correlation between mania symptoms and religious. But we found for example, that patients who had higher levels of intrinsic religiousness, they had 4 times less depression than patients with no intrinsic. But also we found the negative side. This is very important. About 30% of patients report some religious disagreement regarding the treatment. So we know that several bipolar patients, sometimes they stop using mood stabilizers, for example, because of religious problems, religious issues, and then they have relapses, they have depression, sometimes suicide, and things like that. So this is a problem. This was a cross-sectional study published a few years ago, and we just published a 2 years follow-up of that cohort, of that people. So we followed them up for 2 years, trying to investigate how spirit, the outcome. So we investigate here, and what we found actually, that religious, especially the positive and negative religious coping, had an important impact on quality of life. Because after 2 years in the university mood clinic, most of patients improved a lot regarding their mood symptoms. Most of these patients had no depression anymore. They are euthymic. However, they had huge variations in their and more that is not enough, for example, for a bipolar patient to have no more depression or mania episodes. It's important, but it's not enough. Because the patient may have not any more depression, but they are not fully functionally in their quality of life. We are talking more and more about full recovery. Full recovery is much more than mood recovery, and quality of life is one of them. So what you can see here, euthymic patients, euthymic bipolar patients that have no depression and mania anymore, they have a huge difference in quality of life. And look here. The positive religious coping, patients who had a higher level of positive religious coping, they have about 10 points higher quality of life at the World Health Organization, the WHOQOL, World Health Organization Quality of Life score. So they have a much better quality of life 2 years later if they had positive religious coping. However, if they had negative religious coping, they had about 20 points less quality of life score. So as you can see, a huge positive and negative impact, depending on how they use their religion, their spirituality. And one example of negative religious coping is to have a passive deferral. God will solve everything. I don't need to do anything. Or God is punishing me, things like that. In the other side, the positive religious coping is facing a problem, I could ask, well, if God is love, if I'm facing a problem, perhaps there is some lesson that I could learn. Or if I'm facing some problem, God will help me a solution. I will do my best, and the rest, I trust in God. These are some examples of positive religious coping that is related with much better quality of life, and the negative religious coping with worse quality of life. Okay, providing another example. This is about drug use in university students. This is a national sample of Brazilian university students, a sample with 12,000 students around the country. Okay, so we found here basically that the students that are not religious, they had on average twice the chance of using alcohol, tobacco, marijuana, or other drugs in the last month. So we can see here a much higher prevalence of legal or illegal drug use among university students when they are not religious. And this is a very interesting study that we are very happy with this study. This is another psychiatrist from our group. We investigate here the largest sample of crack addicts in the world. This is a sample of 600 crack inpatient addicts, okay? So most of studies until now regarding substance use and religion and spirituality focus on prevention. If people have higher levels of religious involvement, they have lower drug use or lower prevalence of drug dependence. But when this prevention fails, when the person became addicted, had dependence of substance, and specifically a very severe crack dependence. We know that the crack dependence is very severe, and in Brazil have an epidemic of crack dependence. And so evaluating these patients, we investigated their religious history in their teenagers, when they were teenagers. What we found is that specifically the religious frequency and the religious participation when they were between 15 to 17 years age. When they had this religious participation during that period, they had much less severe dependence. In which sense? They had half the chance of starting use. This is a measure of severity. So have half the chance of have very high levels of consumption, more than 10 crack rocks a day. Or they had also a less severe crack craving. So it shows that even when the prevention failed, these people, they had less severe crack dependence. When they were, specifically in this age, probably because at this age they start to have contact with drugs. If they are participating in a religious community, they are less exposed to this, so they are exposed later to drug use, and they become less severely addicted. And also, it's not here, but in another table, we have also found that they had less involved with crime and prostitution related to the drug use. That we know is very frequent in crack addicts, prostitution and crime, robbery, and things like that. Okay? This is exactly the study that the Professor Carnegie showed previously about the suicide. I will skip this. And there is, just now, this month, the JAMA Psychiatry, the Journal of American Medical Association Psychiatry, published a paper, also from that group from Columbia University, for Miriam Weissman, investigating how the religious beliefs involvement of the parents impacts the suicidal ideation. So they investigated, and they showed basically, and they investigated the suicidal ideation and attempts in teenagers. And they showed that parents with the highest level of religious involvement, 80% decrease in suicide ideation and attempts in their offspring. 80%. Even when the children are not religious themselves. So in some sense, it creates an environment different. So it's a very interesting, this just published this month issue of JAMA Psychiatry. Okay? Okay. And this is now changing to another, we talked a lot about mental health problems. Now specifically about a very important problem in physical health. We are talking about in hemodialysis patients, chronic kidney disease, patients on hemodialysis. We also investigated 160 hemodialysis patients, and we investigate their levels of happiness. And first, we were surprised that the average level of happiness is quite good, despite all the impact of hemodialysis, all the impact of chronic renal failure. a lot of change in their bodies, in diet, physical limitations. So their happiness level was quite good. And we were shocked by one first point. The happiness level was not correlated with any physical health variables. Was not correlated to level of an hemoglobin level, was not related to the number of other chronic disease like diabetes, hypertension, things like that, were not correlated with the quality of the hemodialysis procedure that we measure by KTV. So it was not correlated to any of the physical variables, but was correlated with the religious involvement. But with the organizational religiosity was not correlated. So probably because organizational religiosity means church attendance. Because they have some limitations in moving, in going to church, it was not correlated. But their private religiosity, reading religious texts, prayer, or meditation, things like that, or their intrinsic religiosity was correlated with happiness, like sense of coherence, that is how they figure out what is their cognitive framework to deal with struggles, with stress. So as we are doing quite a good job nowadays in medicine in prolonging the life of these people with chronic renal failure, but we need to improve a lot also their happiness and quality of life. And one of the ways to work on this is exactly helping them regarding their religiosity and the sense of coherence. Okay, now another aspect about the definition of spirituality. The spirituality is related to the transcendent, the sacred, the ultimate reality. Is the institutional aspect of this. For most of the world population, spirituality is lived inside a religious framework. But of course, there is, and is growing, the spiritual but not religious also. You need to take in consideration this aspect. And I agree with Dr. Koenig that we need to keep the core of spirituality in the transcendent and the sacred. Because if we remove this, we cannot differentiate it from other ideologies, from other aspects of life. So the sacred and the transcendent seems to be what really connects all the spiritual traditions. Okay? This discussed exactly about the core, the meaning core, the core meaning of spirituality. That's exactly the ideas of transcendent and sacred. And we should not confuse spirituality only with psychological well-being, meaning and purpose. Meaning and purpose, psychological well-being can be outcomes of spiritual involvement, but it's not necessarily the same of... Okay, now the position statement states now some directions, some guidelines for psychiatric practice regarding spirituality. So it tells that a tactful consideration of patients' religious beliefs and practices, as well as their spirituality, should be routinely considered, and sometimes will be essential in psychiatric history-taking. So we need to take the spiritual history of our patients. That's the point. Okay? We need to take the spiritual history of patients, because if you'd like to really have a comprehensive understanding of our patients, we need to take into consideration their spirituality. Of course, for some patients, they can say, oh, spirituality is not important to me. That's fine. And we can ask, what else can give meaning to your life? But for most patients, spirituality will be important to them. And we need to take this in consideration. But there are some barriers to integrating and to taking spiritual history and things like that. This is a study from Brazilian Psychiatry, a national survey among Brazilian psychiatrists, and it has findings very similar to studies performed here in the US by Farr Curling, that the main psychiatrists consider important to integrate spirituality in clinical practice, okay? So on average, 77% of Brazilian psychiatrists consider important to take in consideration that psychiatrists who have a religious affiliation are more likely to say that it is important compared to those without religious affiliation. And what are the major barriers to integrate spirituality? For 30% is the fear of exceeding the role of doctor. They don't know. They are afraid of imposing beliefs. And it's important to say also that there is a risk to impose religious, but also anti-religious beliefs. Because if a patient, for example, claim of some religious beliefs or practice, the professional can have a very negative response. Explaining it away is just immature ego defense, for example, and things like that. It happens quite often, unfortunately. So the other is lack of training and lack of time. So as you can see, the two most frequent barriers were fear of exceeding the role of doctor and the lack of training. And both can be easily overcome with good training. And the WPA is also now currently working on this. And another important thing, the training sometimes is not talking about spirituality, but also can influence in talking negatively about spirituality. Sometimes in our psychiatric training or psychological training, we only have examples of negative using of spirituality. And one interesting finding in this study was that, here in the US, the psychiatrists were usually religious, but less religious than the general Brazilian population. The older the training of the psychiatrists, the less religious they were. So the psychiatrists that received the more recent training were more religious than the older ones. This could be because of the training. Because the training in the past in Brazil was strongly influenced by Freudian ideas, by psychoanalytic ideas that have usually a very negative view of spirituality and of religion. So this is something that needs to be better investigated later, but it's something for us it's a good food to thinking. So this is also a collaborative paper with Herdo Koenig and Giancarlo Lucchetti, is a geriatrician, co-director of our research group in a federal university in Brazil that was cited previously. And we exactly published together a paper with some practical guidelines about how can we integrate this in clinical practice to help psychiatrists and other mental health professionals, and how can we do this. And this paper is also freely available in English, okay, at the internet. So first of all, the treatment needs to be patient-centered, not prescribing, not imposing. It's never a matter of imposing our own religious or anti-religious perspectives. What should matter to the clinician is what matters to the patient. So our major goal is to fulfill the patient needs. So always patient-centered. So we need to take in consideration all aspects, the physical, mental, social, spiritual aspects. We should not choose only one of the aspects. We need to take in consideration everything in our case formulation, but also in our treatment planning. The clinicians need to explore also their own worldview and religious and spiritual history. Because sometimes we can have unsolved issues regarding our own spirituality, in a positive or a negative way. I could feel the urge to convert my patient to my religious or anti-religious views. Some patients claim, well, a physician to my therapist, but when I start to talk about this, the therapist changed the subject of the conversation. Or the therapist start to move in the chair, feel uneasy. The patients are smart. They recognize this. And they understand that they cannot talk about this to do their clinicians. And also, we need to have an open-minded approach with a genuine interest and respect by patients' beliefs, values, and experience. So we can sometimes ask the patient, please educate me about your spiritual background. I know very little about this. I would be very happy if you could educate me a bit about this. How your religious tradition see your problems, the suffering that you are facing, and things like that. It could help us a lot in making connection with the patient, in empowering the patient, and helping the patient to find the best ways to cope with his or her problem. And one way to take a spiritual history, there are several instruments, clinical instruments, that help to take a spiritual history. And Giancarlo also was the first author of a paper that is a systematic review of all the most important available for taking spiritual history. And one of the best is the FICA. The FICA was developed by Christina Puchalski, that was talked about in the beginning, the opening ceremony here of this Congress. And she's from George Washington University. And FICA is very useful because it remembers us. The F of faith is the patient part of any faith community or faith. The I, importance. Is faith important to you? Are you a member of any religious faith? It's important to you. C is community. Are you a member of some faith, spiritual community? And A of addressing. How would you like that we address your spirituality in the treatment? So it takes only 4 to 5 minutes to take. And there are several studies showing that just by taking a spiritual history, the patient rates as much better the quality of the care provided. So it has impact in the perception that the patient has about the quality of the treatment that he or she is receiving. Probably because the patient understands that he or she is being considered as a whole and not just an organ or a piece or a case, things like that. Okay. And also we need to take in consideration that the spirituality and religiosity can be useful to diagnosis, etiology, and the treatment of psychiatric disorders. And we need more research for clinical applications. And the approach must be always person-centered. Always person-centered. Illustrate something about the diagnosis, the importance for the diagnosis, how spirituality can be helpful regarding diagnosis. For example, people that report hearing voices. Are they psychotic? Are they having a spiritual experience? If they are Catholic, charismatics, or they are Protestant Pentecostals, or they are Spiritists, they can hear the Holy Spirit, they can hear a deceased spiritual guide, whatever. How can we make the distinction when it's a schizophrenic symptom or is just a health spiritual experience? And just to show how organization, a very large study, 250,000 people in 52 countries, okay, show the high prevalence of psychotic experience in the previous year. About 12% of people around the globe report any sort of psychotic experience in the previous year. And a psychotic experience of hearing voices, of feeling insertions of thoughts and things like that, that are not related to drug use, sleeping, falling asleep, or when we are waking up. But only 1/10 of these 12% actually had schizophrenia. So basically only 10% of the 12%, 1/10 of them actually had a psychotic disorder. So most people having a psychotic experience are not psychotic at all. So what they have. So that's the point. in the general population in having this experience with poor health, but not necessarily. This is what we will talk about. This is a study, this is the PhD study of my wife, Angelica. Write this journal, this study, about the dangers of labeling as pathological this kind of spiritual experiences. This is, they call the Spiritist madness in Brazil in the early 20th century. But not only in Brazil, in Europe. The spiritualism movement in Europe, United States, in Brazil, were accused of promoting mental disorders, of being one of the major causes of insanity in the country. In Brazil, Europe, and United States. And so many of the top Henry Maudsley, for example, in UK, Charcot in France, and others in Brazil, were strongly in opposition to this religion and send the people to psychiatric hospitals and claiming for legal procedures against these religions. So we faced this kind of problems in the past. And how can we overcome this? We need to study more. So this is one study, for example, with 115 Spiritist mediums. So we performed a very detailed structured psychiatric history and other instruments to evaluate mental health and mental disorders in this sample of 115 mediums. And these mediums, they had high levels of psychotic experience. They hear a voice, they see things, they have possession experience, they have thought insertions, feel insertions that are very schizophrenic symptoms, for example. But we found that they had low prevalence of common mental disorders. We used a scale from the World Health Organization. So the prevalence of anxiety, depression, and psychosomatic symptoms were low in this group, only about 10%. And what was more interesting, there was negative correlation with full trance. The higher the frequency of full trance or incorporation, like Spiritists used to say, the lower the prevalence of depression, anxiety, and psychosomatic symptoms. And also there was a positive correlation with social adjustment by the social adjustment scale. That is a scale developed by Mirna Weissman from Columbia University from that previous study about suicide. So there was positive correlation with higher the frequency of auditory hallucination and full trance, the better the social adjustment. Because there is some discussion about they call the continuum of psychosis. The higher the frequency of the psychotic experience, the worse the mental health. Spiritist mediums. And these papers were published. And we have more recently published some other papers exactly about Puerto Rico patients and also with African Brazilian religions in Brazil, try to differentiate, how can we differentiate a healthy spiritual experience from pathological, psychotic symptoms resembling spiritual experiences. And we also investigated 115 people that seek the help in Spiritist centers because of their psychotic. It's different from that previous sample that were people who are already working regularly as mediums in Spiritist groups. When I say work, I'm saying in having this, not working for money. In Brazil, the Spiritism, people do not charge money, they don't receive, it's only voluntary work. The mediumistic work in Spiritism is always volunteer. So the previous sample was from mediums that have been working as volunteers, as medium for many years. But now it's different. People who are disturbed by their center. It's very common in Brazil, people having this kind of experiences, some kind of anomalous experience, they seek help, usually in evangelical churches or in Spiritist groups. okay? And we found high levels. What they felt? They reported what they called clairvoyance, that is actually visual hallucination, 60% of visual hallucination, auditory hallucination. They had also out-of-body experience, premonitions, all sorts of this anomalous experience. And what's interesting, they did not have levels of psychotic disorders, but they had high levels of anxiety disorders. Because there are some studies showing when people they have this kind of anomalous experience and they do not have a cognitive framework to make sense of them, it causes anxiety because they are afraid. What is this? Usually they are afraid of being crazy or under demonic possession. Neither is good. So they are very, they are very anxious about this, disturbed about this. So, okay. And we did also a 1-year follow-up in this sample. Okay, this is a study that we published together with Robert Cloninger, one of the best experts in personality studies, and also Gordon Claridge from Oxford University, a specialist in schizotypal personality. What we found in a 1-year follow-up, it's interesting because just having unusual experiences, was basically not related with quality of life. What we try to measure? We try to measure which variables and other mental health variables would predict a worse or a better outcome in terms of quality of life 1 year later. Okay, that's the idea. And we saw here unusual experiences, that is exactly having this hearing, seeing, the higher the frequency of this unusual experience were not usually related to quality of life. Neither better, neither worse quality of life. But having self-directedness, that is kind of strength of the ego, is related with better quality of life. What actually was predictor of worse quality of life was introverted anhedonia, that we call in schizophrenia. More and more, we have seen that in terms of schizophrenia, of psychotic symptoms, what we used to call positive psychotic symptoms, hearing things, seeing things, is not a good predictor of schizophrenia or psychotic disorders. The better predictors tend to be the cognitive disorganization and the negative symptoms, blunted affect, social isolation. So we are more and more understanding this now. And I'm sorry, this was the cross-sectional data in the beginning, and the longitudinal data showed that the self-directedness predicted better quality of life, and cognitive disorganization predicted lower quality of life. And unusual experience were not correlated. That's the point, okay? So based on this, we have discussed and published some guidelines to help with these distinctions. We are in the working group of the ICD-11 in helping to propose new criteria for this distinction, and some criteria that help us in the distinction between a healthy spiritual experience from a pathological spiritual experience. For any of these criteria is not perfect. We can find counterexample in any of them, but they help us in our clinical reasoning. The more of these criteria are present, more probably the experience is health. For example, the absence of psychological suffering. The person is having this experience, but it's not suffering. But as we said previously, the suffering can come when the patient does not have a cognitive framework or a supportive, if they feel alienated. Sometimes the major point is the suffering is because of some disturbance caused by the symptom itself, or the suffering is just because feeling alienated because people do not understand what they are experiencing. The absence of social or occupational impairment. The person has this experience, but they still can be productive, functional in different aspects. also the capacity of perceive the unusual or anomalous characters. So they have insight that this experience is different, that people may not understand. This experience is compatible with some religious tradition. We should never forget that spiritual traditions have millennia of experience of dealing with spiritual experiences. So they have their own taxonomy. They have their categories. They have described these experiences and the evolution of these experiences. So sometimes, even if the experience does not fit in the patient's own spiritual tradition, but this experience fits in other spiritual traditions, so it suggests us that this could be non-pathological. It's quite often also, we can see, for example, in Brazil, quite often, sometimes people from Spiritist centers, from Umbanda centers, they refer people from their groups to psychiatrists, saying, oh, what they are having is not what we call mediumship or mediumism, is different. So they need to. The absence of psychiatric comorbidity, that's the point. We cannot trust only in these sensorial perceptions, in hearing, seeing, in this experience. Are there other psychiatric symptoms like cognitive disorganization, what can I do here? Thumbs up. Oh, so fast. Okay, I will stop. And so this is important. So let me just skip for the. I'm sorry. Let me just skip to the end. So why should we integrate religion, spirituality, and mental health? Because most of the world's population has religion and spirituality. It's a usual coping strategy, usually positive, but also negative. It impacts health. Address religious spirituality, impact prognosis, and impacts also the patient rapport with clinicians. Patients want that clinician address religion and spirituality. It's a component of an integral patient's assessment, and it's recommended by many medical and health organizations. Just to have an idea, the Joint Commission is the most important institution for quality accreditation in healthcare here in the US, requires that the institutions take in consideration spirituality of their patients. And in order to help also the continuous medical and health education, our group has created a YouTube channel we call TV NUPES. NUPES is the name of our research group. It's a bilingual YouTube channel in Portuguese and English. Every week has a new short video, 3 to 5 minutes, covering different aspects on religion, spirituality, health, and science. We have people from psychiatry, psychology, neuroscience, theology, philosophy, history, covering the most different aspects about religion, spirituality. Also, below each video, there are also several references for someone that would like to go further. And so it's a good source for continual education. And here are my contacts, and also the email, the website in English of our research group, and also the website of the WPA section on religion, spirituality, and psychiatry.